everybody. Good morning. I'm Margaret Owen, and I'm the director for UT Dallas's Center for Children and Families. And it's my pleasure to welcome all of you here to our spring lecture series. In our lecture series, the center brings you the latest research on children and families from the faculty from the School of Behavioral and Brain Sciences at UT Dallas. And I'm just so very pleased to see so many of you here today. And we'll be interested to hear where you're from and hope you signed in. I would like to introduce and pass the mic to Dr. Deborah Wiebe, who is a core member of the faculty for the Center for Behavioral and Brain, for the Center for Children and Families. And Dr. Wiebe is going to introduce our speaker. She organized this spring lecture series, and I'm very pleased to pass the mic to her.
It's so nice to see so many people here. Can you hear me? Okay. We are so happy to have a lineup of really top-notch speakers this spring, focusing on infant development. And this is to sort of help to launch our infant development program that we can talk to you more about after our talk. Today's speaker, I'm honored to introduce Dr. Pam Rollins. Dr. Rollins is an associate professor here in Communication Disorders program within the School of Behavioral Brain Sciences at UT Dallas and the Callier Center for Communication Disorders. Dr. Rollins received her master's degree from the University of Wisconsin in 1983. In communication disorders, and it was right around that time that she began working as a speech-language pathologist with children with autism. And you have an expert here who is going to be talking about her experiences and her research with autism. She has been working continuously with that population for over 25 years. So she has a wealth of both research and clinical experience. Pam got her doctoral degree in 1994 from Harvard in psychology and human development, after which she joined the faculty here at UT Dallas. When she came here, she helped develop and then directed the, let me get this right, Early Communication Language Social Skills Program for children with autism spectrum disorder. And she is currently a member of the Texas Council on Autism and Pervasive Developmental Disorders. So we're in for a treat. Today, her research focuses on early social skills and later language development in both typically developing and autism spectrum disorder, and we're going to hear all about it right now. Let me introduce Pam.
See if I can get this on. It's so great to see everybody here today. A lot of people that I know from all different places. Okay. Can you hear me? Yes? Great. It's great to be here. I'm really talking about something I'm really passionate about. As she said, I've been working in this area in one way or another for over 25 years, and I love to talk about it. So the name of the talk is Words Are Not Enough, Social Communication and Early Signs of Autism Spectrum Disorders. And so what I'm going to do is kind of work the title backwards in my talk. I'm going to talk to you a little bit about what autism spectrum disorders are and some of the common questions that I get I'll answer. And then I'm going to talk about the importance of early identification. And in doing that, what I'm really going to need to do is to outline for you social development in infants, because social development is the foundation for social communication and something that goes wrong a lot of the times with the children with autism. And in so doing, I'm hoping to show you why just talking, why if kids have words, it's not enough for social communication, and that it's a red flag. So hopefully I'll accomplish all of that today, and then I'll give you some resources if you're concerned about children. So what do I mean by autism spectrum disorders? A lot of people have heard of autistic disorders, Asperger's, pervasive developmental disorders not otherwise specified. Autism spectrum disorders encompasses all of those. It is a heterogeneous disorder that's a neurodevelopmental disorder. And what has happened is that in practice, people cannot do a good, reliable job distinguishing between all of the different disorders. So it's become to be known as a spectrum disorder, where all of these fall under the spectrum. And it's very heterogeneous. People all have common symptomatology, but can range very, very widely in how severe the symptoms are, and or how where their intelligence are. And so the core deficits, the things that bring all of those disorders together as an autism spectrum disorder, is a deficit in social communication and interaction. And what we mean by social communication and interaction is a nonverbal communication, nonverbal or verbal communication for social interaction, and the lack of social reciprocity, that back and forth nature that starts very early in infancy, as we'll be talking about. They also tend to have restricted repertoire of interests and activities. So it's these core deficits that unify all of the different disorders that constitute the autism spectrum disorders. Now, one of the things that people always ask me is about what is the current prevalence and why does it seem to be a rise. Well, right now, the American Academy of Pediatrics is estimating that it's 1 in every 91 children. And the Center for Disease Control is saying 1 in every 100 children. And these figures came out last November, and Center for Disease Control before that was saying 1 in 150 children. So these are the newest prevalence rates. And the question that comes up is, what is the reason for the increase in prevalence? When I started working with the disorder in 1982, it was considered a low incidence disorder, and there was about 4 in every 10,000 was what the estimates were in those days. I worked in a lot of psychiatric hospitals because that's where we used to find them, and most of the kids we saw then had severe intellectual impairments that were also there. We now know that many children, about 50% of the kids have intellectual impairments, but about 50% of the kids don't have intellectual impairments. So why do we see more of them at this point in time? There's definitely unidentified environmental, genetic, and epigenetic factors, and we know that it's a genetic disorder. But I'm not really going to go into that today because that's really a topic of a whole different talk than the one I'm giving today. I will talk a little bit about the change in the diagnostic criterion, and this has definitely been there. When I started working with kids with autism, they were still called autism and schizophrenics, and the literature on autism also talked about them as childhood schizophrenics. So that's really changed since then. And as we got to know more about the disorder and included more people, more high-functioning individuals, the diagnostic criterion changed over time. Specifically, a big change happened in 1994 when Asperger's disorder first showed up as part of the diagnostic criterion for autism spectrum disorders. Asperger's are much higher functioning children. They tend to talk. They tend to get through school without problems, with some problems, but they tend to get through schools. We've all knew them on the playground when we were going to school. They were there, but they just weren't part of the diagnostic category. So that has really opened things up for more people and seeing that more higher functioning individual in there. The other thing that happened in 1990, the Individuals with Disabilities Act of 1990 for the first time included autism as a diagnostic category for to be educated within the public school system. Before 1990, you had to be speech impaired, intellectually challenged, emotionally disturbed to be served within the public schools. So that changed in 1990. In 1993 was the first time that the school systems asked for people to begin to record autism, but it wasn't required until 1994. So when you look at that data, it's there's non-existence before 1990, goes up in 1993 and goes way up in 1994. So there has been some diagnostic substitution that has gone on. Now that's not the whole story, and I'm not minimizing the unidentified environmental, genetic, and epigenetic factors, but all of these things have occurred. The other thing that's happened is an increased awareness of those core deficits. As I said, now you can see a child who has these core deficits who doesn't necessarily have retardation associated with it, and that's something that we weren't really seeing way back in the 80s. There was just a study that came out a couple of weeks ago from Columbia University that studied communities in California. And what they found in that study is that the prevalence rates were higher in communities that had more awareness about the disorder than communities that didn't have awareness about the disorder. It's not that their kids aren't there, it's just they're being found when people have awareness about the disorder. Well, I think it's really important and to have awareness about the disorder, and so that's why I give talks like this, because I think people need to understand what these core features are. And this is just a map of Texas and just what is going on here. This is divided up by the Health and Human Services divisions, and it is last year. We had this done last year with the 1 in 150 criterion, and this is a guesstimate of how many children you would expect to see in the state of Texas who have autism spectrum disorders. Well, we find that, of course, in the cities, which has the denser population, there's more people. But when we begin to look at who we know, who is being identified, we're getting closer in the Metroplex, and we're getting closer in the Houston and the Gulf area, where there's more resources available, more diagnosticians, more hospitals. We're seeing more prevalence in these areas than we're seeing in other regions, like down in the valley. It almost doesn't exist in Brownsville. It's not because there's none of these kids there. It's because there really aren't any diagnosticians there or people who really know about the disorder. So this whole issue about awareness, for me, is really, really important. Well, why do I think it's so important? Okay, and I think it's important to learn the signs and act early. The reason for me it's so important is that early identification leads usually to an early diagnosis. And early diagnosis leads to early services. Now, it's not that I'm diagnosis happy, and I think that every child should get a diagnosis. A lot of people don't like diagnosis or in early childhood. But a diagnosis often is what you need to give you entree to the appropriate early intensive intervention that these kind of kids need. So it's important if it's going to open the doors for services. Now, you don't need a diagnosis to have services, because we don't treat the disorder, we treat the behaviors. And if you go to a speech pathologist is going to look at the behaviors and treat the behaviors. So it's not that you need that diagnosis, but the type of intensive intervention that you need often doesn't come without that diagnosis. So that's where I really push on that diagnosis. I know there's a lot of people who say, well, we don't like to diagnose kids early. But early services and the right early intervention has been shown over and over again to lead to better outcomes. And that is the big thing. There's a lot of things we don't know about autism, but what we do know is that early intensive intervention leads to better outcomes, saves billions of dollars across the lifespan of children, and ameliorates some of the disorder. And that's really good. I mean, if we can get them early and get them more social and get them doing more interacting and having better outcomes, that's right now where the state of the research is, and that's, I think, what needs to be done. So I think it's important that people learn the signs and act early. So what's early? How early can autism be identified? Well, the current research says that with someone who understands the disorder, a reliable diagnosis can be made between 18 and 24 months. So that's important. But what do the signs look like between 18 to 24 months? The signs may be a little bit different in a child 18 to 24 months. What we find is the social communication impairment in these children is there. And sometimes, not all the times, but sometimes the restricted repertoire of activities and interests may not yet be evident. Sometimes in some children that doesn't come in until closer to 3. But that social communication impairment is there. And what we know is that autism is really the only disorder that has early social impairment, early social communication impairment. Children who have intellectual deficits also have a social communication impairment, but their impairment is equal across the board with their other skills. The children with autism have skills that seem to be higher than their social communication impairment. So it's really important to look at what we're talking about in terms of a social communication impairment. So what I want to do with you now is I want to talk about early social development. And I'm going to talk about it in terms of the 2-month transition, which we call sharing emotions, the 6 to 9-month-old transition, which we call pursuing goals, and then the 12-month transition, which we call sharing intentions. So sharing emotions. This is the time, about 2 months of age, that parents wait for, where they see the child do a social smile. Prior to that time, the infant had been a ball of reflexes, and now the mom or the father, I say mom a lot, I mean child caregiver whenever I say mom, just let me tell you right there, looks at the baby, and there's that social responsiveness from the baby. The baby is giving that social smile. These interactions are face-to-face. I use the word dyadic because it's only between the caregiver and the child. It has to do with no outside entity like an object or an event, just face-to-face interaction. And what happens often in these kinds of interactions is something that we call Proto Conversations. And it's interesting that cross-cultural research has found that children in all cultures participate in some form of proto conversations. And I think that's really interesting because not all cultures have that real face-to-face interactions that our Western cultures have. Proto conversations are reciprocal exchanges of emotion. Now notice I said reciprocal. I mean turn-taking sequences when I'm talking about reciprocal. But I didn't say imitation. So it doesn't have to be a direct imitation. It can be in a different modality. So the mom might look at the baby and say, oh, and the baby will go, ah, right? And use their hands to show that emotion. So it is cross-modality, but it's this reciprocal exchanges of emotions that's happening. Babies are learning lots about self and other and emotions during this time. There's mutual gazing where the baby looks into the caregiver's eyes and uses this gazing a lot to help regulate the interaction. So the baby will look away when they're overstimulated and then look back when they want to engage. Babies does a lot of responding to vocalizations and facial expressions, and I think this is really important. A lot of people are hesitant to vocalize with their babies. And it's really good if you begin to vocalize with your baby, they begin to vocalize back, and you get these really nice turn-taking experiences. I can't tell you how many times I'm with babies and the mom says, wow, you really get them to talk. And they're very young. But it's these back and forth sequences, and they're really important sequences to do. So that's the 2-month transition when they're sharing emotion. About 6 to 9 months of age, the interaction shifts to now from a dyadic to a triadic interaction. Here, again, what I mean is triadic is there's a third object. In this situation, we've got the block here. So it's the mom and the baby directed towards the block. And in this triadic interaction that I'm going to talk about, in the time of sharing perception and pursuing goals, they're both directed towards the block. They're not directed to the other. What you find is the baby is goal-directed at this time. The baby has selective attention to the goal, so she's looking at that block. She might want it. She's not looking at anything else because that's her goal. She wants to be looking at that, okay? If she wants that, she's going to persist till the goal is met. So she's going to go after that. When the goal's met, she's going to be happy. When the goal's not met, you know what she's going to be. Okay, so she's got a goal towards the block. She also understands now that the mom or the other is also goal-directed. So if the mom shifts her eyes to something, the baby may look to see where the mom is looking. This helps the baby to predict what's coming next and to learn a lot about the world. So if the mom decides she's going to build a block tower and she picks up a block and she puts it on another block, the baby says, I can predict what I should be doing, and I'm going to put a block on the block tower because I've got that same goal. And there might be a turn-taking sequence that happens. And that's really great. What's not happening in this interaction is the baby's not looking back at the mom. The baby is sharing her perception with the mom, but the baby is not looking back and going, oh, do you see what we're doing? Isn't this great? We're sharing this together. That's not happening here. Okay? And this is really, really important. There's a lot of good learning that's going on here, especially when you move on to the next stage. But when you don't move on to the next stage, things get limited. Many of my kids with autism get to this stage. They don't get to the next stage. We're going to talk about the consequences in that in terms of social communication. But remember, kids with autism can get to this stage. The next stage, of course, is now they're looking at each other building the block tower. Now they're sharing that block tower. What's happening, I call this shared attention and intention. And what's happening now is the baby knows that the mom can be looking at lots of different things in the world. And the baby knows that she can, that she wants the mom to be looking at what she's looking at. So she has to do something to say, look at what I'm looking at. And we'll talk about that in terms of communication. The other thing that's happening is they can begin to coordinate their plans. So the mom might hold the block tower at the base so that the baby can put it up, and vice versa. So there's role reversibility that begins to happen at this time. And that's the sharing attention and intention. And one of the areas that I've done a lot of research in is the next step, which is the social communication that we'll talk about. But it's also the transition between sharing perceptions and sharing attentions. I'm very interested in this area because it's that problem of kids with autism. They can share perceptions and be goal-directed, but how do we get them to share attentions and intentions? That seems to be much more difficult. So now let's take all of this social development that we've talked about and put it into communication. Between 9 to 12 months of age, typical children begin to communicate for 4 different communicative intentions. This starts at the nonverbal stage, and then it moves into verbal language. So they begin to do social routines, wave bye-bye, and play peekaboo. They begin to share attention, so they begin to show. You don't need language to do this, right? And remember what I talked about when you share attention and intention. You're saying, I'm showing you this. I know you can look at lots of other things, but I want you to look at this, and I want to look at this with you. Are you looking at this with me? They also can then direct attention. There's the exit sign. But they do it because they want to share that information. That pointing, we find that social pointing, just to share information, does not happen at the right time in kids that have autism. It's a real difficult thing for them. So they do those types of things. Of course, with language, you'd say look, or you'd say it's a red block, right? So that you can do that with language or without language. The last thing that they do is they request or protest. You can do that non-verbally to request, very conventional, or you could cry, right? Or you could say, verbally, you could say cup, if you wanted the cup, right? Or you could say no if you wanted to protest. So this starts in the nonverbal segment and moves into children who have more verbal language. So now I want to take those social communication, those communicative intentions that I just laid out, and talk about what the underlying cognitive, the cognitive underpinnings are for them. So when we look at requesting and protesting, what we find is that they only need to pursue goals, right? They don't have to have shared attention. In order to get shared attention, sharing and directing attention, you have to have that sharing attention and sharing intention that I talked about. These are very different. Now remember, I told you that kids with autism can pursue goals. Guess what? When kids with autism begin to have intentions, sometimes it takes a long time before they have intentions, but when they begin to have intentions, they do it for requesting and protesting. They do it for that in the absence of sharing and directing attention. This, again, is an area that I've done a lot of research in both typically developing children and children with autism. And so the big problem for kids with autism is they can request and they can protest, but they're not using full, real, sharing social communication, right? Because they're not really paying attention to the other. They're just really paying attention to their own wants and needs. And in order to have social communication, which would be the sharing and directing, you need to have this shared intention that I told you about. Now, there's one more step to this. Pursuing goals, right, can get isolated words. Pursuing goals, right, we talked about I could say cup if I wanted your cup, or purple if I wanted your purple cup back there. I can use words, but this is where I get very passionate about the idea that words are not enough. You can have words, but you can have words without true social communication. You can have words, and typically developing kids will get about 50-word stage, up to the 50-word stage in this area. It's a very perceptual mechanism. But you need true sharing of attention. You really need true social communication for you to develop true rule-governed language. And so this is a problem that I see with a lot of intervention programs. A lot of intervention programs, they keep working on requesting. They're not understanding the difference between these two cognitive underpinnings, and kids like to request, and they can get them to request, so of course you feel good when you're being successful. But what you're doing is you're only giving them words and isolated words. You're not teaching them how to communicate. You need to work on things that's going to get to this shared intentionality, which is not easy, but that's a lot of what I try to do in therapy, is to try to move this into shared intentionality to really help them develop true rule-governed language. So that's what I meant by words is not enough. So what I hope I've helped you see is that social development is really important. And I hope that I've helped you fine-tune your eyes to the difference between sharing perceptions and pursuing goals and sharing intention. Because I want you to be able to see in a baby if the baby is not beginning to share attention and intention, and not beginning to do those early social communicative acts that we've talked about. When parents go to the pediatrician will often say, "Does your child talk?" Well, you can say, "Yeah, my child talks." But the question isn't, does your child talk? Does your child use words? But how does your child use words? For what communicative functions does your child use words? And that's the that's my big bandbox that I'm always on. It's not if they're using words. It's how they're using words, and are they using words for social communication. So I hope that I've helped you see that words are not enough, and why words are not enough, especially in the case of autism. Well, I told you a while back that a reliable diagnosis can happen at 18 to 24 months. And this is a list of early indicators of for children with autism. It comes from a lot of the work that Amy Weatherby in Florida has done, as well as some people in Chapel Hill. And this is important to share with physicians when they're doing surveillance and other types of things. But let's go through what these are. Early indicators. You should be worried if you have no warm, joyful engagement by 5 months of age. Now remember, I told you a little while ago that typical babies start that about 2 months of age. So if they're not doing it by 5 months of age, that's a problem. There's no two-way back and forth gesturing, smiling, social, emotional reciprocity by 9 months. Again, something that's starting much earlier on. So I'm not trying to be an alarmist. I'm not saying go out and get all concerned if it's not happening at 2 months. Wait a little bit. But if by 5 and 9 months you're not seeing these things, be concerned. By 12 months, limited use of communicative gestures and words. Note, showing, waving, pointing, and shared attention. Requesting is not on that list. Protesting is not on that list, okay? Now you know why. Okay. Limited use of back and forth interactions like peekaboo. Doesn't follow the adult's gaze or point. We talked about that way back. They're doing that in the sharing of perceptions stage. Doesn't respond to the name or any loss of any language or babbling or social skills. A loss of skills is a problem. So that's what you should be looking at in the early stages, or looking at if it's not there in the early stages. So what to do if you're concerned. Talk to your doctor or nurse and ask about a referral to a pediatrician or a developmental pediatrician or other specialists. Contact your local early intervention agency, and this is on your handout. I've given you the website in Texas to look for where your early intervention agency is. A comment about early intervention. Early intervention will not diagnose autism. They will say whether or not you can, you meet criterion for getting into early intervention. So you will not get the appropriate services for autism, but having early intervention in your life is still an important thing and really full of resources. So you need to do something more than early intervention, but they're a place that can help you with those resources if you need them. If you're above 3, contact your local public school. And for information, there's lots and lots and lots and lots of websites, and I've chosen the Act Early website is a good one, and these should be on your handout. The other places to contact that are really very UTD specific is right here, the Center for Children and Families Infant Developmental Program. They do low-cost screenings. If you think your child may have autism, if that's your concern, make sure that you mention that so they can pull the correct screening to do, because it will be a little bit different. We also have the Crystal Charity Ball Autism Project Coordinated Referrals Services, and there's one number that you can call to get access to lots of information and referrals and things like that. We're trying to develop a one-stop shopping number because there's so many resources out there, and some are good and some are bad, and parents really don't know where to go. So we're trying to remedy that. And then Callier Center for Communication Disorders, and I put the numbers for both the Richardson and Dallas campus. Social communication is the purview of a speech pathologist. If those of you who are my students, you know this is what I teach about, right? So early social communication. You don't need to have words. You don't need to know how to talk to see a speech pathologist. You can be pre-verbal to see a speech pathologist. We have individual programs and group and classroom-based programs as well. So it's always a good place to go. So those are some of the resources that I have gotten together for you. And I really appreciate your time.
Thank you so much. That was really interesting and very informative. We have time for some questions, so we'll do that for a while. Do you have any questions? Yes.
Have you come across any ABA programs in the area that do a good job of not only emphasizing the word acquisition, but also the shared intention and attention?
That was our conversation over here, and you may know the answer better than I do. I think that some of the people who do the more contemporary ABA programs, they do it ABA is applied behavioral analysis, which is one of the treatments for autism, and there's different types of ABA. There's the very discrete trial type, and which you're giving a child, let's say, a card or a stimulus, and they need to respond. And then there's more contemporary, which looks a lot more like transactional developmental approaches. That is what I do. And it depends on the therapist, in a sense, that there are therapists who come from a developmental background and they incorporate that into their ABAs much more. Some of the pivotal response people incorporate it much more, but I find that it's often therapist specific. Knowing exactly what program a therapist is doing doesn't always tell you how she will do it or he will do it, because if they come from a discrete trial background into a contemporary ABA program, they're going to look more discrete trial. Does that make and then sometimes if they come from a more developmental background, they look a lot like the transactional people. So it kind of, did I answer your question? Okay. But it's a really hard thing, and we were talking about that before, that a lot of the ABA programs were trying to work on sharing attention, and they work on the surface structure, and the literature on that is beginning to say, you know, you can work on the surface, it's not going to get it there. They have to be developmentally ready to do it. So what I've done in my research and I've done in my clinical practice is really focus on what can we be doing, right, is something to help push that shared intentionality. And I have a bunch of things that I think are working, but I'm still researching that. Thanks.
Can you talk a little bit more about what those things are that you're doing to try to encourage the shared attention for kids who don't want to do that?
Yeah. Well, in what wasn't here, well, I use a lot of routines so that there's a lot of predictability, and so that I can decrease the cognitive load on the child, and they know what's kind of coming next. So I kind of try to create an environment that is going to let them not use a lot of other cognitive skills to figure out what's coming next and where they're going, so that when we do something, it kind of gets highlighted in the foreground for them. And one of, I guess, if I had to pick one thing that I do is in the literature that I really was talking about here, we talk about joint cooperative activities, that when you have shared attention and intention, you are doing a joint cooperative activity. And that means both people know that they're interacting with each other. It means that you are doing something that has role reversibility in it, okay? So there's a few rules that go along with that. So when you look at like the baby with the block, the mom in the block, okay? And I tell this to my students all the time. When speech pathologists are doing language stimulation a lot of the time, they get into that shared perception stance and they talk about what the child is doing and what the child is looking at, right? That's fine for a typically developing kid who's going to look back and say, oh yeah, okay, cool, I know what you're talking about. But a kid who's only at that shared perception stage, they're going to be sitting there and they're going to be like, oh, I'm so happy that she's not bothering me and I get to play with what I want to play with, and she's talking about, I've tuned her out already, okay? So you have to turn the interaction so that you're really in a face-to-face interaction. You have to do something that there's some kind of reversibility of roles in that interaction, and that you have to do something that has mutual knowledge. So, I mean, this is a little thing, but I see a lot of people who will play blocks with the kids. Well, the kids are going off and doing all this stuff, and they're like, you know, the clinician's just following them around, right? The kid really doesn't care. Well, I mean, if you think about what Legos do, right? Legos gives you a picture of what it is you're going to be building, right? Well, if you show them a picture of what it is you might be building together, well, then you have some hope of getting mutual knowledge. What kinds of things can you do in your environment to create mutual knowledge, even if it's just that piece before you get to role reversibility, so that you're working together and you're forcing the work together with keeping the kid regulated. You know, you have to step back and you have to be a good clinician within that. But if you just are following the kid and talking about what the kid is doing and they're at shared perception, what I see over and over again, they're just so happy you're not bothering them. And then what people do is end up going into requesting with them, because then you're getting kind of a response. You've got to figure out how to do that shared cooperative activities, right, without needing to rely on any requests. Yeah.
I just kind of wanted to comment maybe on her question.
Yeah.
This kind of goes to what we were talking about earlier. But some ABA programs...
Talk loud.
Okay, sorry. Some ABA programs that I'm aware of are, like Easter Seals has a program where, yes, they are focusing on functional communication, but also things like building rapport, and when you're building rapport, you're measuring things like, is the child approaching you? How can I get the child to approach me more? Looking at engagement programs where the child is, are they just interested in these tangible items? How can I increase the social activities and things like that? So I think looking at programs that incorporate those components are important. And I know I could speak up like Easter Seals, maybe being one of them that do, but you're right, it's very individualized to the therapist.
That would be a more contemporary ABA program.
Definitely, yeah.
Great, thanks. Anybody else? Yes.
This may be sort of a chicken or the egg type question, but do you think that making the transition from the pursuing goals to shared intention is these kids lack the ability to do it, or they lack the interest in developing that sort of communication? Does that make sense?
Yeah, no, that makes a lot of sense. I think that there's both, to be honest. I think that they do lack interest, and as they get older and they have some of it, because what we do find is that at every level of communication, even when they're doing, my dissertation many years ago was with high-functioning kids with autism who had grammar and were communicating, but they did a lot less shared communication than other kinds, and they weren't very interested in communicating, even once they got the skill. I think that it's a hard place to get over. I think if it was just interest in infancy, we would see more kids getting it, because they do have restricted interest. You can work within their restricted interest to get them to do something. So you can find ways to motivate kids. So if it was just interest, then I don't think it'd be as pervasive. But I do think as they grow, that does come into it. And anybody have a different answer? Because I know there's other autism experts in the room. Margaret.
Well, I agree with you. Just some high-functioning autistic individuals who I know very well, who are now in their 20s, I've perceived it, and they've perceived it, and people who know them have perceived it as a lack of ability, but they also have now awareness that they lack that ability and desire to learn ways of working around that lack of ability and learning more routines, learning more acceptable ways of trying to get there. And it is a different route.
But it's a different route, and this is a little sketchy, but I find, and other people find, that the kids who tend to be more Asperger's, they're the ones who care. Yeah. The kids who tend to be high-functioning autism, they don't care.
Well, I was talking about Asperger's.
Yeah.
Yes. Which I know we're supposed to get away from using.
Right. So I said that in the sense that that's going to be true for some, but there's going to be another subset who aren't going to be motivated to do the strategies to help them do better. Right. So that you're going to get both kinds.
And I'm also thinking about kids who have had many people around them working on helping them to perceive their problems and how to get there. Right. A lot of work.
Right. Yeah, there's a lot. And there's also, I talked about special interests. I interviewed a man, I guess he was in high school a couple of years ago, and his special interests were football and poker. And he had lots of friends. He did great because his special interests were things, and everybody, he knew all the stats, and he could play poker better than anybody else. And they were wanting him around all the time, and he was doing great. So it's really, when your special interests and you have gained more shared attention, are related, that's really good. But when your special interests are something very obscure, there's a lot more problems in that. So, yeah.
A lot of times with children on the spectrum, we see they have no eye contact.
Yes.
And that's probably the first goal we write, to increase eye contact. Now, a lot of times the eye contact is lacking because it's difficult for them to make that eye contact in a social way. Now, is it right for us to work on that and constantly tell them to make the eye contact, or put things in front of our eyes so that they look at us, even though socially it's difficult for them to do things like that?
Okay, you're going to get a very Pam Rollins answer on this one. Yeah. It depends on what your goal is at a specific time. I often go, they're also, what we didn't talk about, they're also really bad little ones at symbolic play. And I use the 3 strikes and you're out rule. Right? If you're trying to teach them to communicate about something and you're trying to teach them how to make eye contact at the same time, and it's going to dysregulate them to make eye contact, the fact that they're dysregulated, they're going to become anomic at that moment, right? Just as when we get dysregulated, we can't talk as well, right? So if you're making eye contact and it's dysregulating them, they're not going to get their words out. So maybe if you want them to communicate something for them, you can ease down, but it's within an interaction that you're doing, and you might be like going back and forth between eye contact and then communicating something and eye contact, and hopefully getting them comfortable with a routine that you can get both of them in. But if you are teaching a new skill and you load them with 3 things that are hard for them, and you've got, I call this the 3 strikes and you're out, you're not going to get very far with that. So you have to pay attention to how regulated their system is at a time, what you can be doing to keep them regulated in that interaction. Eye contact and communication and more routine activities that are easier for them, that are more predictable. But anything that's brand new for them, you're going to be setting yourself up.
Okay, I want to invite, we can continue the discussion. Pam will be around. We have a reception right outside the door here. So I think we'll be able to continue to discuss and answer questions for anybody who has them. Before you take off, let me make a couple of announcements. One, I want to introduce Emily. Would you stand up so that people can see who you are? Emily Touchstone is heading up the Infant Development Program, and she's on your Contact This Person list. So if you want to catch her at the reception, that's who she is. And the second thing I wanted to announce is we have an evaluation form. We would love to know sort of who you are, who our audience is, and whether we're reaching the different kinds of people that we want to reach with these lectures. And we also really want to know if you have ideas of things you would like to hear in the future, because these are lecture series that we plan to do every year. And then one last thing is, if you didn't get one, make sure you pick up one of the postcards that has all of the remaining lecture series this spring, because we have one a month through May. So thank you, Pam, and thank you.